Hamilton is another member of our emergency medicine physician group here at Cincinnati. He's medical director and also medical director for Cincinnati Fire and EMS for pediatric side. So he's going to give us some up-to-date information on how should we or what should we do about immobilizing these children.
Thanks, Rich. Welcome. So as Dr. Falcone said, I have a love for and niche in pediatric EMS. I'm one of the few also pediatricians in the United States that's actually board certified in EMS medicine. That's a fairly new specialty, actually, and I'd love to talk to you about this. So what I want to impress upon you is that there's a lot of conflicting information out there for pre-hospital providers about spinal immobilization. Maybe some of you are familiar with it, maybe not, but there is a program that is that's an educational program for pre-hospital providers that's called PEP, P-E-P-P, and it's Pediatric Education for Pre-Hospital Providers. This program has been around since 1990, the beginnings of it, and it's a joint effort between the American College of Emergency Physicians and the American Academy of Pediatrics, and it is an evidence-based educational program that basically gives soup to nuts pre-hospital providers pediatric education, which is sorely needed. And I put up two basically quotations from their teaching resources. One is that spinal immobilization is therefore essential for every child who sustains a suspicious mechanism of injury where head, neck, or spine may be involved, who has pain or tenderness of the spine, and who has signs or symptoms of weakness or loss of sensation. There's also one that says, whenever the mechanism of injury, signs, or symptoms suggest possible spinal injury, the entire spine must be stabilized. This is best performed with the patient supine on a rigid spine board and in a neutral inline position. And this is the most recent version of PEP. So these are basically the expectations that are taught of pre-hospital providers for trauma care of a pediatric patient. So do pre-hospital providers do this? This was a study that was done in published in 2013, which really showed that there is tremendous variability in the correct immobilization of patients who really meet those criteria for immobilization. So this was a fairly large study, had 540 children with cervical spine, potential for cervical spine injuries, and looked at immobilization practices and really showed that once you get to be around less than 8 years of age, the practices of properly and fully immobilizing a C-spine dropped off significantly. The top line is basically full immobilization, and then the lines under there are other types of immobilization or even no immobilization whatsoever. But around 8 years of age, it began to steady out and approximate more what is done for adults. So why doesn't EMS properly immobilize children? It's a very hot topic in pediatric emergency medical services, and it's likely multifactorial. In fact, it is. It's not just likely. There is clearly EMS has an uneasiness with young children in general, and their abilities to assess pain. There was a study that was actually done looking at around the United States the amount of pediatrics in pre-hospital education in terms of certifying paramedics, like their initial certification, and really only about 40% of programs had 10 hours or less of pediatrics. So there is, in the total number of what can be up to 1,000 hours of training that it can take to get your paramedic certification, to have only a very fraction of that be pediatrics means that you're going to come out of your training and perhaps not be as comfortable. There's also an EMS perception of limited options for immobilizing young children. There's a dearth of appropriately sized equipment when you look nationally, especially in rural areas that are often more strapped for resources. So whether it's perception or reality, there is a feeling that for the youngest of kids, we really don't have appropriate ways of immobilizing them in full spinal precautions. And then for the more sophisticated paramedics and pre-hospital providers that are interested in looking up and learning the evidence, and they either through their continuing education or their own research really find that there really is a lack of evidence for the efficacy of spinal immobilization in children, although there is some for adults. And then when they dig even a little deeper, more recently actually, there's some evidence suggesting that perhaps we're even causing harm by inappropriately and indiscriminately immobilizing some of these children just based off those sort of blanket statements that you saw on the slide from PEP. This makes it even more challenging for the pre-hospital providers, and this is actually, and I talked about sort of the conflicting information that they hear. So here is from the American College of Emergency Physicians. Their board of directors had a position statement in 2015. So at the same time, they're hearing and learning from the PEP course, they're hearing things like this. Evolving scientific evidence demonstrates that some of these current out-of-hospital care practices cause harm, including airway compromise, respiratory impairment, aspiration, tissue ischemia, increased ICP and pain, and can result in increased use of diagnostic imaging and mortality. So you can imagine, you as a provider, you're hearing a lot of conflicting information particularly. And then, the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma in 2013, also put forth these statements. So long backboards are commonly used to attempt to provide rigid spinal immobilization among emergency medical services trauma patients. However, the benefit of long backboards is largely unproven, and that spinal precautions can be maintained by application of a rigid cervical collar and securing the patient firmly to the EMS stretcher. So you can really get a sense of, if you're a pre-hospital provider and really tuned in to what's current practice, you're getting a lot of conflicting information. And really it's because the landscape of adult pre-hospital spinal immobilization is really changing. And these are just sort of a selection of some studies that really speak to that. So there was a study in 1994 where they took a selection of healthy volunteers and immobilized them for 30 minutes. What a great study to do. Sort of one of those studies you wish you thought of, and then measured their pain afterwards. These people had no issues beforehand, and many of them had pain, right after they were taken off the backboard. But 6 of them still had significant pain at 48 hours. So you can imagine, if you have contusions, even fractures, sprains, what immobilizing on a backboard does to your pain as well. Another study in 1998 followed 129 patients who were immobilized, and 60% of them, after a period of time, also had increased neck and back pain, regardless of what their injuries were. There are also studies that show that pulmonary function after lying flat on a backboard after a period of time is decreased. And then that other studies, more recently in 2014, that really showed ill-fitting seat collars can actually worsen a cervical spine injury. And as those of us who do the clinical work of trauma know, that it can lead to difficulty in appropriate airway management, can cause some pressure ulcers, and certainly increases the chances of our needing to do additional radiologic sort of studies when we judge a lot of those based off how their pain is. I think that it's been shown very clearly now that although pre-hospital providers tended to immobilize every single trauma patient, they're also hearing that certain patient populations don't need immobilization anymore. So the clear one is gunshot wound victims, and they're clearly being immobilized less. When that was studied, those immobilized were twice as likely to die, and you can see that the number needed to treat was tremendous, and the number needed to harm is on there as well. The many protocols are also sort of moving towards selective spinal immobilization too. So, and this is primarily for adults. So again, to emphasize that pre-hospital providers are hearing a tremendous amount of change in the adult world and not as much in the pediatric world, and that can be confusing at times. So there are studies like Nexus that was done that had 818 C-spine injuries, and they were basically able to derive a selective immobilization rule from that basically hinged on mental status, intoxication, distracting injury, neurologic exam, and midline C-spine tenderness. And if somebody didn't have any of those, then there are protocols for pre-hospital providers to not immobilize those patients in the field. Another important one was out of Canada, the Canadian C-spine rule, and that also had similar factors that operationalized allow pre-hospital providers to be selective and not bring every single trauma patient in full spine precautions. The other thing that pre-hospital providers are exposed to are alternatives to rigid long boards, and there are a lot of these vacuum spine boards that are out there that actually are wonderful, and so they allow a patient's spine to be in a very neutral position, in a position of comfort, and basically to fill in the gaps to keep that spine immobilized, and that is felt, particularly in the adult world, to be a very, very important and viable alternative to a long spine board. So how appropriate? So there's this whole breadth of change in how adult C-spines are being managed, and basically spinal immobilization is being managed pre-hospitally. So how should that inform a change in practice to pediatric pre-hospital spine immobilization? I'll go through that a little bit with you. There has been important work that's been done on this. A lot of it is still pending. This was a study done by Julie Leonard, who's at Nationwide Children's, and this basically looked at the potential adverse effects of spinal immobilization in children, and that was basically 285 patients who presented to an ED, and you can see a portion of those were immobilized and 112 of those were not. There was one significant cervical spine injury in that, which statistically fits to around sort of the statistic is about 1% to 2% of patients will have a cervical spine injury. So, and you can see that the effects of spinal immobilization in children, and if you see that for patients who did not have, who were immobilized and did not have cervical spine injury, you can see that they had increased pain scores, up to 2 times, increased pain, and that their spine was imaged more often. You can see the odds ratio on the right side there, and that it also contributed heavily to whether or not they were admitted to the floor or to the ICU, sort of as well. And this was again sort of regardless of their injury, because the majority of these patients didn't have injuries.
Can I interrupt for a second? Because I have a question. I'm not quite sure I understand how to interpret that study. So it was a retrospective look at 285 patients.
Yep.
And so since it wasn't done prospectively, which would be hard to do, wouldn't there be a bias towards those that did come in collared or came in immobilized, had some reason of the history or something that made them immobilized, and that's why they got more
Yes, that's exactly the point of the study.
So it's not because of the immobilization, it's just that...
It's because of... It probably is because of the immobilization. It's probably because our pretest probability is probably higher when a patient comes in immobilized, that we actually probably do more because we probably think, oh, the pre-hospital providers felt like this was a significant amount significant injury. So, and that actually is played out in other literature too, that what pre-hospital providers, the care that they begin in the field, often influences actually what we do in the emergency department. But also by them being immobilized, if for all comers immobilization in some degree increases their pain, then patients who didn't necessarily need to be immobilized is because they're reporting back on a pain score, are we therefore doing more for them because their pain score is higher, and therefore we feel like, oh, there's a greater chance that they actually have injury.
But I would say that there's a chance that the emergency room providers followed through with radiation or followed through with the radiographic studies for the same bias that made the EMS put the collar on in the
Absolutely. So
independent, even if they never saw it, they'd have to be almost blind. Even if they didn't see the collar, they might still have a higher chance of getting imaging because of the same reason that they had a higher chance of getting immobilized.
Yes.
So it's an interesting study. I don't know how to interpret it.
Well, prospective studies are actually sort of, there are plans to do prospective studies around that, but this, as I said, this is not an unusual finding that the course that pre-hospital providers set does influence sort of what we do. It's that way, with asthma. If when patients get started on on certain asthma protocols, we more quickly sort of and more diligently treat their asthma. Certainly for pain, when this is well described as when EMS actually treats a patient's pain, we're faster and more diligent in the ED about timely and adequate pain management. So
interesting.
Okay. It's a very interesting phenomenon. Julie Leonard and her group also did another study that sort of looked at factors associated with cervical spine injury in children after blunt trauma, and this was basically a case control study. It was a very large one, 17 hospitals, patients that presented after blunt trauma and who received cervical spine radiographs, was 540 children with cervical spine injury, and basically found that the factors that you see on the right side there, also again with their adjusted odds ratio, that those factors, having one or more of those, was 98% sensitive, 28% specific for cervical spine injury, and that although 98% isn't 100%, that it would have identified 98% of the children with cervical spine injury and reduced exposure to cervical immobilization and radiation for those who didn't have cervical spine injuries, if somehow this was built into some sort of tool. The other thing that has been well described, since you can see 1998, is that immobilization practices for children are really not that great, especially on a longboard. And really, if you see the top picture that really shows an adult immobilized on a standard backboard, that same practice in a young child really flexes their neck. And that what's more appropriate is probably something like this, where either the pre-hospital providers elevate the shoulders, which is actually very similar to when patients come in with football helmets and pads on, and you have to match up the football helmet and the pads because one without the other puts their neck out of alignment when they're lying down. So either boards that have a well there that the head can rest in, or elevating the shoulders is probably more appropriate, but in practice this is done very, very rarely. Lastly, there are NASEMSO is the National Association of State EMS officials, and so 2014 they came out with a spinal care protocol for pre-hospital providers that basically also incorporates children as well. Now there's not a tremendous amount of prospective evidence for this, but they felt like it was able to be some of it was able to be extracted from adults. And so this is actually out there, and it's a model protocol sort of guideline that EMS agencies could use to address spinal precautions in adults and children. And this is something that is important, but again, the prospective studies haven't necessarily been done to fully support all of these, recommendations. And I won't, it's on your screen. I won't necessarily read that. But basically, if none of those above factors, as you can see on the left-hand side, apply, then the patient should not have a cervical collar placed. So really, there really is, just as you said, a desperate need for the development and validation of a pediatric cervical spine injury risk assessment tool. I'm very happy to say that that work is really underway with Julie Leonard and her team, and actually here at Cincinnati we're actually honored to be a part of that too. And it is a lot of stuff has been done retrospectively. There has been some prospective work that's been done and completed and not yet published about how often pre-hospital providers' physical exams correlate with our exams in the emergency department. And the next step is actually, and that's in the works, is prospective work on validating and creation of a tool and validating that. So I really believe that likely within certainly most of our academic careers, we will see a worthwhile and validated tool that will help pre-hospital providers so that they can identify, just as in adults, comfortably identify which patients need to be immobilized, which don't, and that will, improve the standardization of practice around this, and also probably decrease any potential harm that we cause, any morbidity that we cause to children who present to our emergency departments with blunt trauma.
Hamilton, that was great, and obviously adds a lot of answers some questions, but certainly adds more questions. I think obviously we all care about not harming kids. So I think the issues you raise of the increased pain from the backboard prompting more studies and prompting more work. I still think we're struggling with how do you balance the risk of making, if they had the rare case they had a spinal cord injury or a spine injury of some sort, making it worse by not immobilizing them. I'm sure, I know that's what makes us all anxious. That's what causes us sometimes to put immobilized kids once they get here, if they weren't immobilized, that underlying fear of causing harm. So thoughts that you might have to add to what you've already shared?
Yeah, so what's particularly frustrating to pre-hospital providers is they'll go through full spinal precautions on a patient, and they bring them into the emergency department, and these are patients that our trauma team doesn't necessarily see, right? Because these are patients who are managed entirely by emergency medicine. The pre-hospital providers have done a very diligent job of bringing these patients in, and what's the first thing we do? We very quickly assess this patient as an emergency medicine physician, and then take all the stuff off and put the child in the mom's arms. So why are we basing that? And we're basing that on sort of inherently our experience, and that we think that this was a low risk mechanism, and that the child looks well, and by glancing at them and seeing that they're moving around their neck, they're not in pain. So we very quickly sort of do this for ourselves. So what we really need is the prospective studies and work so that we can objectify those gut feelings and that experience and make it okay for EMS to basically do the same thing. Yeah, I hope that sort of answered.
No, it's a challenging question.
Yeah.
And I think we'll have more discussion this afternoon when Dr. Pia talks about clearing the cervical C-spine as well. So I just want to take a quick second. We'll come back as a group after this early session for other questions. But any comments from the panel? I know we have our neurosurgeon waiting in bay to comment and talk later. But any comment from our other ED faculty or Becky or our neurosurgeons right now?
So I have a question.
Or Todd.
This is always going to be me. So I have questions about the C-spine, but I'll wait till later. The backboard, this is after transport.
Yeah.
Now I'm talking about once they're there. When are we supposed to get them off the backboard? Is it better to keep them on during all the imaging? Is it better to get them off immediately? What's the standard of care right now on that? I don't know.
So we get them off the backboard as soon as we possibly can. And so we will get them off when we typically roll the patient as part of our secondary survey, our ACLS, our ATLS secondary survey, and get that out. Because, I mean, really, so even somebody honestly who has a thoracic or lumbar fracture, if they're lying flat and we consider that they're going to be safe that way.
Do your beds have a slot to put the films under the patient, or do you have to lift up the patient?
So we usually do it all at the same time. So we roll the patient, pull out the board, put the X-ray plates sort of under them, and sort of do it as one.
And the scanner, you just use a sheet.
Yes. Yeah.
Okay.
I think the key there is Hamilton's point out. I mean, the key is to get them off that board early, so they don't get more pain, pressure ulcers, and other problems, because otherwise people forget later on in the process. But it's also important to keep the team aware that just because you got them off the backboard doesn't mean they're cleared.
Right.
They still need log roll precautions and until you're confident that they don't have an injury.
And the other reason we want to roll them rather quickly too is it's also our reminder to look for any additional injuries on the back of them. So it sort of serves multiple purposes.
Yeah, actually, sorry, for those of you watching out there, if you're watching this in full screen, where you get the gorgeous view of Rich Falcone's face taking up your entire monitor, then you won't see the chat. So once in a while, you may want to make the screen smaller so you can see the discussion, put some questions. We really want questions from the audience here to help spark discussion. So go back and forth.
I had one other comment, Hamilton. In addition to those patients that are well enough that only emergency medicine treats, the concern also is for the sicker patients who, because we are working desperately to help their ABCs, we may not get them off the board as quickly as desirable. And so it's just as important in the very ill patients as well as the well patients to get them off the backboard as quickly as we can, while also trying to stabilize them. And I find anecdotally those are the patients that are the most challenging for me to get off the board quickly.
That's great. It's a great discussion. We'll come back to more comments as we go through, but I'll pass it back to Becky to kind of talk us through the case a little more.